we all are pretty much a tube when you think about it. You know, food goes in one end, comes out the other. It's a curvy tube, but it's still a tube. Now we've got some things coming off of the tube. We've got appendages. Not all animals do. Worms are pretty obviously a tube. But this tube body plan, right? It kind of describes the digestive system. You know, goes in one end, comes out the other. There's some swellings in the tube, but it's basically a tube. The tube plan is also used in the nervous system. So of course we start life as a single cell, and this grows into a ball of cells. It'll flatten into a disc. It'll kind of eat itself, sort of. It goes through gastrulation and forms 3 germ layers. And then after that, we finally start making tubes. So we start off as a ball, turn into a disc, then we turn into a bunch of tubes. We'll cover that turning into a tube in the first part. And what we're talking about there is neurulation. And that's just separating the nervous system from the rest of the skin. After that, we'll talk about neural tube defects. And we're going to focus on spina bifida because this has better survivability than other neural tube defects, as we will see. But here's an example of failed neurulation. And when neurulation fails, we get ourselves a neural tube defect. This is a case of spina bifida. So the spine is left open rather than sealing the back. It remains split open in two. Okay, there we go. All right, so we're going to start our journey from after gastrulation when we're 3 principal germ layers. Ectoderm on the outside, the mesoderm in the middle, and the endoderm in the centermost part of the body. That's going to form the digestive tract. The mesoderm will make the musculoskeletal system, and then the ectoderm makes the nervous system in the skin. Wouldn't you know it? Seems strange that the nervous system and skin are derived from the same segment, but that's the way things work. So we're a disc at this point. You can see in the movie. What it's starting to do is sort of invaginate right in the middle. Right? It forms the primitive streak. The cells along the midline are going to expand in number, and there will be an inward migration. And what this causes is a deeper invagination called the neural groove. On both sides, we have our neural folds. These are eventually going to meet around the future back of the neck. Somewhere in that area, they're going to zipper up together and extend to the head and to the tail. And that's what we see here. Those neural folds are zippering up. So we're going from a sheet to a tube. Look at that. We got a tube. Now on each side of the future spinal cord there, we got our somites. That's portions of the mesoderm that are going to create the musculoskeletal components of each body segment. They're doing a little rotation here. You can see they're highlighting the neural tube. Parts of the neural tube are going to form the brain. Other parts will form the spinal cord, but the neural tube creates our central nervous system. The peripheral nervous system is derived from something called the neural crest. And the neural crest just reminds us it's difficult to cleanly separate 2 things. You know, if you slice off a piece of bread, there's always some crumbs. That's what we're dealing with here, the crumbs. Okay, let's have a look at the micrograph format for those enthusiasts in the class. So midline, we got that kind of swelling that occurs. So after the primitive groove forms there, we saw that swelling. That's the neural plate. So just division of cells. They grow along the midline to form the neural plate. That inward migration of cells is going to push up the tissue to form the neural groove right here. These are the neural folds. The neural groove is nice down in here, that little valley. As development progresses. The two neural folds there are going to touch together. The yellow is going to fuse. That's the future nervous system. The green here is the rest of the ectoderm that forms the epidermis. That fuses green to green, yellow to yellow. And in the end, what we're left with is a tube covered by a sheet of skin. All right, let's see if this is going to behave for us today. So what we're doing, we're starting off as basically a disc of tissue. We're going to have a little invagination in the middle. The cells are going to migrate toward the center. All right, so let's do like a little cross section through here. We got our outer layer. That's the ectoderm. Then we have the middle, mesoderm. And of course, they're not just straight lines, but bear with me here. I'm kind of drawing blindly. And then we have the innermost endoderm. The endoderm forms the gut, mesoderm forms the musculoskeletal system, and the ectoderm forms the skin and nervous tissue. All right, so what's going to happen here? The mesoderm we should actually think of as kind of like a bow tie, I suppose. Shouldn't be joined. So we got our somites, these little blobs of tissues that are going to make the muscles and skin. We got this central structure called the notochord. Oh boy, we're acting up. Okay. It should be an O. Notochord. Isn't this painful? All right. Overlying that, we have the ectoderm. Here's an important thing to keep in mind. The ectoderm is connected to the notochord. And we have the endoderm. I'm not going to draw it because we don't care about it for the purposes of this discussion. All right, so what's going to happen? Cells are going to migrate toward the middle. Right, so the ectodermal cells are going to have this kind of central migration. They're going to all move toward the middle because the weather's nice or whatever is going on there. So that's going to push up and kind of create these little mountains of cells. Right, we still got our notochord here kind of holding everything in place. And flanking it, we have our somites. Now, because the notochord tethers the ectoderm in place, it doesn't shift when the cells start moving around. So the midline stays in the middle, but we build up these neural folds. See how it folds over? That's my neural folds. Okay, that's enough of this. Okay. In the middle, we have our neural groove. All right, so let's continue over time here. All right, head on down. Eventually, our neural folds touch. All right, we're not quite separated yet. Notochord on the bottom, somites on the side. Now we're going to do the old switcheroo. So anything that's future nervous system is going to stick. Anything that's future skin is going to stick to future skin. And so right here, we're going to be left with an overlying sheet of ectoderm. The neural tube is going to separate off of that. This used to be the neural plate, became the neural groove with some neural folds. When the neural folds touch and fuse, and separate from the overlying ectoderm. So this is still the ectoderm. Now it's going to make our epidermis. The notochord is down here. That's not what I'm talking about. The neural tube here. This used to be on the outside, but notice now it's buried. It's covered with future skin. So we still got our somites here. All right, that's going to be our future musculoskeletal system. And then this thing right here, this is our neural tube. Nifty stuff. That separation, though, isn't clean, so there's a few cells that break off. They don't live in the neural tube. They are free to roam about the cell, so what they do is migrate into the somites and create the peripheral ganglia. So these create our peripheral nervous system. The dorsal root ganglia, the autonomic ganglia that are scattered throughout the body, those are all derived from yikes. Neural crest cells. That's what makes our peripheral nervous system. So those are the free cells that kind of break off during neurulation. That's what's going on here. They just don't show us the little bit of neural crest that breaks off. So the closure starts somewhere around around the back of the neck, shoulder area, and then it zippers up. Sometimes there's multiple closure events and they all meet together. In some species, it's just one closure. Doesn't matter. We close up somewhere in the middle and zipper up. Now, if we don't zipper up fully, if we don't actually fold over our neural plate into a neural tube and separate it from the ectoderm, that's when we have neural tube defects. And they can occur during this closure, going down into the spinal cord, that'd be our spina bifida, or they can occur during the cranial closure. Right? In that case, we're going to have failed neural tube development of the brain, so we'll have exposed brain instead of spinal cord. Definitely not a good thing. Now, primary neurulation doesn't build the entire spinal cord. It only builds down into the initial segments of the sacral spinal cord. The bottom of the spinal cord develops through secondary neurulation. So rather than going from a plate into a tube, here we're going to start off as a solid mass of cells and just hollow out. Okay, what might that look like? Who knows if this is going to cooperate. All right, so we got our neural tube. Here's my future brain here. I'll just draw some little eye spots. Maybe give it a couple of lobes here. This is just so it doesn't look horribly obscene. All right. And that goes down, my goodness, to around S2. The rest of the neurulation that occurs here, that's the brain, by the way, up there. The rest of the spinal cord develops by first creating a solid mass of cells called the medullary cord. All right, let's look at a cross section through here. So it starts off as a solid tissue, no hole in the middle. Rather than turning a sheet into a tube, we're going to take a solid rod and hollow out the middle. So we're going to carve out the middle of this and then fuse it onto the rest. And now we have ourselves a complete spinal cord. So primary neurulation is where we take the ectoderm and fold it over to form a tube. Secondary neurulation is where we take a solid rod called the medullary cord and then hollow it out. Again, to make a tube. It's all about making a tube. The last thing we need to do is build the spine. Build the actual bony structures of the spine. So, derived from the somites, we're going to have these structures called the neural arches. The notochord is going to turn into the centrum. So the notochord is there during development. It's really helpful. It doesn't remain the notochord. It turns into the vertebral body, eventually a bit of bone. We have these paired arches that need to grow backward and fuse together. This is the last little bit of development. Let's get this mutated worm out of here. So we got our neural tube. Now if we're in, of course, the head region, we're not dealing with spine development. There we're going to fuse together some plates of bone. All right, so we got our neural tube here. Let's just call that NT. Down below, it's the notochord. The notochord turns into the centrum. And then we have these neural arches. These are paired structures that flank the neural tube. And these are going to grow toward the center. Right, so they'll extend centrally, eventually fusing together to form a single bony structure. Sometimes this process fails. Our neural arches don't grow together. And we have now an area of exposed neural tube, eventually spinal cord. These will also grow down, fusing with the centrum as well. So we'll create the vertebrae by taking separate structures and fusing them together. Well, this process can go wrong too. So we can have issues with neurulation, or we can have issues with the actual development of the spine itself, the bony structures. And with spina bifida, here we're just dealing with abnormal spinal cord development. It could be neurulation. Again, it could be that bone development as well. So the worst kinds of neural tube defects are those that arise because of failed neurulation. This creates open neural tube defects. So in primary neurulation, if that fails, if we don't fold the sheet over to form a tube, we leave the sheet open, now we have nervous tissue exposed. That's not a good thing. So we could have failed cranial neurulation. That's going to cause the brain matter to extrude from the head there. That's not a good thing. So when they're born, brain matter is long gone, and we see anencephaly, the lack of a brain. Clearly poor outcomes. When we have failed spinal neurulation, that's what gives us spina bifida. Right? This still sucks. No doubt about that. But spinal cord, if we have low enough injuries, we can probably spare vital functions, and there we'll just have sensory motor and autonomic problems, as opposed to death before or shortly after birth. That's what we're going to have with our cranial failures in neurulation. Sometimes both of these happen together, and that's called craniorachesthesis. Don't make me say that again. So, failure with cranial neurulation, we're going to see death. If it's high enough in the spinal cord, we could also see death in case there's difficulties with respiration. But spinal cord failures is going to lead to paralysis, loss of sensation at and below the level of the lesion. That motor and sensory deficits, that's going to also include autonomic issues as well. And if we leave it open like we see here, we have exposed nervous tissue. This is a major risk for infection, so we need to get this covered up. All right, there's 4 types of spina bifida. The most common is spina bifida occulta, and that's what we see here in panel A. In this case, all we have is a failure of the neural arches to fuse together. And that's it. You might see a little hairy patch of skin over the area. I'm not sure why, but whenever the nervous tissue has better contact with the skin, it leads to hair formation. I don't know what goes on there. Usually this is discovered accidentally, just because some imaging is performed on the back and they happen to notice that you have a failure to fuse. So you don't see motor or sensory deficits, just a little hairy skin. The other types of spina bifida will create some kind of sensory motor deficits. Okay, going from least to most severe, meningocele. In this case, the meninges protrude out of the spine. So here we made our tube, but it poked out. So in all cases, the vertebrae aren't developing properly. With occulta, everything remained where it was supposed to be. Then we have our herniation neural tube defects. Meningocele, just the meninges poke out. This is obviously not a good thing. This needs to be fixed. But because the spinal tissue remains in place and hasn't herniated, the outcomes are much better. Myelomeningocele. Okay, we folded up, we made our tube, we had a herniation, and in this case, nervous tissue herniated out. That's the myelo component. The worst outcome is with myelocele. So we're not talking about problems with the meninges because they didn't really form. We didn't actually fold our plate up into a tube. We left it open. So myelocele is the open neural tube defect for spina bifida. Worst outcomes. This needs to be repaired immediately. This will be fatal because the CSF is just leaking out. So not only is there a risk of infection, you're just dumping fluid out. So very serious, life-threatening. Okay, as far as birth defects go, neural tube defects are the second most common birth defect. So the prevalence there, you can see 20 to 200 per 100,000. The risk factors associated with neural tube defects. Of course, a family history. A family history of neural tube defects suggests that there could be some mutations that are being handed down that affect the process of folding up a sheet into a tube, breaking off the tube cleanly, and then having the neural arches fused together. So something in spinal development is not going right in the family. So the genetic cause gets handed down. So family history, that's a clear risk factor. There are also external risk factors that can increase the risk of neural tube defects, such as the use of anticonvulsants. These anticonvulsants, especially when taken during the first trimester, can increase the risk about tenfold. Here we're seeing an odds ratio of only about 2.4. So it depends on when they're used. In the first trimester, very high risk of neural tube defects. I'm not sure how. They must have something to do with perhaps folic acid metabolism and then folding over. I'm not sure the mechanism here, but there's a very clear increase in risk with anticonvulsant use, such as valproate, during the first trimester. Another risk factor is low folic acid or folate intake. And in fact, now it's standard practice to prescribe prenatal vitamins, which include folic acid, because folic acid reduces the risk of neural tube defects. I'm not sure the mechanism here, but clearly folic acid is important for proper neurulation and spine development. Metabolic problems with the mother, such as diabetes or maternal obesity, are also risk factors for neural tube defects. The symptoms that emerge with spina bifida, of course, include sensory motor deficits arising around the lumbosacral spine. So, closer to the bottom. This is, of course, more likely to be affected. The lower you are in the spine, the more likely it is to be affected, because the lesion affects where it occurs and everywhere below. So at the level of the lesion, we'll see flaccid paralysis. In other words, weakness or inability to move, without an increase in muscle tone. And that's because at the level of the lesion, we've killed off the neurons. We've killed off the lower motor neurons so they can't innervate the muscle. The muscle can't have any tone. Below the level of the lesion, you can see some spastic paralysis where there's an increase in muscle tone. But at the level of the lesion, flaccid paralysis. And of course, sensory loss below the level of the lesion too. Right? Recall that the spinal cord is the connection between the body and the brain. And so if I'm a sensory neuron innervating the legs here, right, the front of the legs, I'm going to live in the dorsal root ganglion in the lumbar spine. If I have to pass up through a damaged portion of the spinal cord, my axons are toast. I can't communicate beyond that damage, and so feeling will be lost in the area that's innervated there. Now, of course, down at the bottom of the spinal cord, S2, S3, S4, this is very important for bladder and bowel control because this contains the preganglionic parasympathetic neurons that stimulate release from the bladder and bowels. So you'll see incontinence fairly commonly because, again, we're down at the bottom of the spinal cord. So an injury here or above will affect it. Now, the different spinal levels can work on different flexors, extensors. We might also damage one side more than the other, creating an imbalance of muscle strength at joints that create musculoskeletal deformities, such as scoliosis, for example. And then the reduced movement that occurs can create ulcers. Of course, reduced sensation doesn't let you know that an area is sore, again, increasing the risk of ulcer formation. Another potential problem is hydrocephalus, or the buildup of fluid in the brain. And this is because of malformation of the nervous system. Right, that's going to affect the formation of the ventricular system, preventing fluid from draining. All right, before we get onto that, let's just remind ourselves what scoliosis looks like. Right, so you can see musculoskeletal deformities because there's an imbalance acting on these joints. Hydrocephalus is exactly what it sounds like, water in the brain. Right, so we got our ventricular system, lateral ventricles feeding into the third ventricle, feeding down into the fourth ventricle. There's a couple of holes we can exit. We can also head down into the spinal cord. In spina bifida, when we don't have that clean separation of nervous tissue from skin, so in the herniation spina bifidas, or even worse, myelocele, without cleanly separating nervous tissue from skin, that can cause some pulling. It can cause herniation of other areas. We tend to see something called Chiari malformations. That's just herniation of brain tissue down into the spinal cord. So the gray matter here, that's being herniated downward. When we herniate our cerebellum, for example, or our medulla down into the spinal canal, that's going to put pressure on the ventricular system, closing it off, and we're still making fluid. So we're just going to build up fluid and it's going to balloon here. It has nowhere to go. That's our hydrocephalus. These Chiari malformations can also damage tissue and allow for the creation of fluid-filled cysts, these syringomyelia here. Those fluid-filled cysts are going to put pressure on the tracts, motor tracts, for example, to create spasticity or weakness. They can also affect brainstem function, so our sense of balance can be thrown off. And then, of course, if we're affecting the medulla, we can have respiratory problems. So these brainstem abnormalities that also occur with spina bifida, these are another serious problem for us. The way that we deal with spina bifida is ideally to prevent it. So the use of folic acid supplements can reduce the risk of neural tube defects. So it's better to prevent it than to get it and treat it. Now, how we deal with the symptoms if they occur, well, that varies depending on what the symptom is. For incontinence, there are medications that can be used to treat incontinence depending on what type we're dealing with. For example, if we have excessive output of the parasympathetic nervous system because of damage above the sacral spinal cord. So if we have spasticity, for example, in bladder contraction, anticholinergics can help this because the parasympathetic nervous system releases acetylcholine. So we can antagonize acetylcholine receptors and decrease spasticity. Also, timing fluid intake can help. And of course, catheters, timed enemas, these can help allow for the evacuation of bladder and bowels in a controlled environment as opposed to just when you're in the middle of class or something like that. Hydrocephalus is treated by the insertion of a shunt. So we can insert a little catheter into the ventricles themselves. Okay, so these ventricles are all swollen up over here. Put a catheter in. The fluid that's building up can be removed and then drained out externally. So this catheter, look, we're sitting out here outside of the skull. That's going to drain on down into the intraperitoneal cavity there. So rather than having the fluid move down within the nervous system, we'll take it out and just dump it in the gut. That will dramatically improve hydrocephalus. So we won't have the buildup of fluid, we won't be putting pressure on the brain. That pressure is not benign. Pressure can stimulate neurons, it can close off blood vessels. You don't want to walk around with a head full of water. So the ICV shunt, intracerebroventricular shunt, can help remove that excess fluid. So we just stick a catheter into the ventricles. Bing, bang, boom. Now, surgical repair is also another option, and this does need to be considered in any of the cases where we have certainly an open neural tube defect or a herniation. We need to repair that surgically. The only one that's not going to need surgical repair is occulta, but that won't really cause any problems for you. All other cases, we need surgical repair. That's the treatment. We gotta fix it. So this can be done pre or postnatally. Postnatally, it can be done to, for example, cover up the exposed nervous tissue, also to correct any of the musculoskeletal complications that might arise. Prenatally, we can repair the neural tube before birth, which causes a dramatic improvement in survivability as well as developmental outcomes. So here's just a little schematic. When they notice through imaging some kind of open neural tube defect or something like that, they can go in, surgically repair it, right? So we can actually go ahead and close up the neural tube, close up the meninges. So now we don't have the open neural tube defect. Hopefully development can go a little closer to normal. We can save as many of the spinal neurons as possible and thus improve mobility and survivability. So if we compare, for example, hindbrain herniation, so those Chiari malformations, that herniation of hindbrain tissue into the spine, we compare whether that occurs. Remember, bad stuff always goes on the left, good stuff on the right. When we have prenatal repair versus postnatal repair. So you can see here about 96% of our postnatal repair still had a Chiari malformation. Only 64% with prenatal had a Chiari malformation. Is this different? Well, let's look at our relative risk, 0.67. Okay, it's not 1, so that's good. It's less than 1, telling us that the risk of a Chiari malformation is lower in our experimental group. That's the prenatal surgery here. Let's look at our 95% confidence intervals, because we can't go through more than about 20 minutes of our life without thinking about a 95% confidence interval. Notice it doesn't include 1. So we have a significant reduction in risk, in other words. Okay, number needed to treat, 4. That means if we were to perform prenatal surgery in 4 kids compared to postnatal surgery in 4 kids, we would have helped 1 additional child that we wouldn't have otherwise helped. That's it. So for every 4 surgeries, you're helping an additional child not have Chiari malformation. So the lower the number needed to treat, the better. Okay, there's development. How about an actual functional outcome, like the ability to walk? Of course, bad stuff is on the left, so the inability to walk is shown over here. The ability to walk is over on the right. Again, prenatal on top, postnatal on bottom. We can look at our event rates. Clearly it's lower here. Is it significant? Well, let's look at our relative risk, and the 95% confidence interval doesn't include 1, so we have a significant reduction in the risk of being unable to walk independently. To word that more normally, we are more likely to be able to walk independently when we have prenatal repair of the neural tube defect. Number needed to treat, 5. Of course, there's a range of possible truths for that, but 5 is pretty good. Now, this isn't without risk. So surgical repair increases the risk of tethered cord syndrome, and that's exactly what it sounds like. All right, recall that that spinal cord doesn't run all the way down to the bottom of the spine. We got our cauda equina here. Hopefully this does it. Okay, cool. All right. So early on in development, the spinal cord goes all the way down to the bottom of the spine. Oh goodness, I'm just going to draw these bigger. Perfect. Drawing circles really taxes the computer. Okay. So as we develop further, the spinal cord doesn't get any bigger. You can see here it shrank. No, it doesn't get any bigger, but the spinal column is going to get bigger. Okay, so the bony structures are going to continue to develop downward. So if my spinal cord gets tethered in place, maybe because of scar tissue from a surgery, as normal spine development continues and the bones extend and grow downward, that's going to stretch my spinal cord with it. Oh no, that's not a good thing. You can probably imagine that neurons don't like to be stretched. And you're totally right, they don't. So with tethered cord syndrome, instead of having the spinal cord end somewhere around OL2, something like that, it gets stretched down to wherever it was tethered. Now, what causes tethered cord syndrome? Well, it could be failed separation of neural tube from the ectoderm. That can certainly do it. It could be some sort of abnormal growth. It could also be that surgical repair. So when you get in, start cutting stuff up, you form scar tissue. Scar tissue is very sticky. So the spinal cord, while it's much better to be covered up and separated from the skin, it's not fully separated because there's maybe a little scar tissue holding it in place. So while surgical repair is wonderful and will increase functional outcomes, over time, sensory motor deficits might develop. So if we see progressive worsening of motor, sensory, and autonomic function, we might wonder whether there's a little tethered cord syndrome going on. Another thing that will be experienced with tethered cord syndrome is back pain, because we're stretching the nerves. The treatment here, more surgery. You just got to get in there, separate the spinal cord from the scar tissue that's holding it in place, and hopefully that fixes it and you don't get another round of scar tissue. After that, of course, physical therapy, occupational therapy. We want to increase the range of motion, strength. Teach them how to use their assistive devices, things like that. You know what you do. All right, so I got a few review questions that you can go through here. Make sure you've got your neurulation down, so understand primary. Actually, we don't need to see this. Make sure you understand primary and secondary neurulation, how those are different from one another. Well, maybe we should see this actually. When you're thinking about your lesions, for example, and why is it that bladder and bowel dysfunction is so common. All right, just don't forget the spinal cord is there to connect the brain to the rest of the body. So running through the spinal cord, we have a bunch of tracts, right? Going top to bottom. So when we have damage high up in the spinal cord, this area is damaged, but so are all the axons that pass through it. So we're going to deprive all of the rest of the spinal cord below the level of the injury of innervation. And I'm not going to try to write on here anymore. So we no longer have input to these lower segments. So let's say that I'm an autonomic neuron living down in the sacral spinal cord. I need to know when it's appropriate to urinate. I need to have some sort of descending input to tell me that. Well, if I have damage in the spinal cord anywhere above S2, I'm not getting that input. So my activity is no longer based on what ought to occur. I just kind of run on autopilot. We'll talk a little bit more about that with spinal cord injury. But review those, the different types of spina bifida as well, and just consider the various treatments that are available. If you have any questions, fill out the questions box. Let me know what's tricky. I'll see you in class.